Today we will discuss about an emerging zoonotic infection, monkeypox. Monkeypox is an enveloped brick-shaped virus. It is about 200 to 250 nanometers in size. It has characteristic surface tubules and has a dumbbell-shaped core component made up of a linear double-stranded DNA. Monkeypox belongs to orthopox virus, which also includes smallpox, vaccinia, cowpox, and rabbitpox. Monkeypox was first discovered in 1958 in two colonies of monkeys in a research lab in Copenhagen. Following this, the first human case was reported from Congo in 1970. The term monkeypox is actually a misnomer as monkeys are not the common host of this virus. The exact reservoir is still unknown. However, African rodents such as rope squirrel, tree squirrel, Gambian pouch rats, dormice, and prairie dogs have commonly been the host from where the monkeypox virus have been isolated. The common mode of acquiring this infection may be from an animal to human or through human to human transmission. Animal to human transmission occurs commonly through bites or scratches from an infected animal. Human to human transmission may occur due to direct contact of skin lesions or body fluids and respiratory droplets through breaches in skin of a non-infected individual, or indirectly through direct contact of the contaminated material. The recent epidemic also implicates sexual contact as another mode of transmission of this virus. There are two distinct genetic clades which are identified: the Central African or the Congo Basin and the West African. The Central African clade is believed to have higher severity of illness with higher case fatality rate. Following the first human case report from Congo Basin, there were multiple epidemics which happened in various parts of Africa. The first case which was reported outside Africa was in USA in 2003, where a young child was reported to be ill following monkeypox infection. Gambian pouch rats were implicated to be the host during this epidemic. There were multiple other case reports which were reported subsequently in various parts of the world. The present outbreak started in Europe in May 2022. Following the first case, monkeypox infection spread to different parts of Europe as well as to USA and Australia. The present outbreak is quite similar to the West African clade, which carries a fatality rate of less than 1%. The median incubation period of monkeypox is usually 7 to 14 days. However, infection can occur between 5 to 21 days following exposure. The common symptoms include fever of more than 38 degrees, chills, malaise, headache, and lymphadenopathy. Lymphadenopathy is a distinct feature that distinguishes monkeypox infection from smallpox. Following the prodromal phase, the characteristic rash appears within 1 to 2 days following the fever. The rash usually begins on the face and then spreads to the trunk and the palms and soles, following a centrifugal distribution. The initial phase of rash begins as a macular lesion, following which it develops into papule and later becomes a vesicle or a pustular lesion. After a week, usually these lesions tend to scab and crust, leaving a hypopigmented lesion at the sides of the scar. A suspected case is defined by acute onset of fever, headache, lymphadenopathy, myalgia and intense asthenia, and progressively developing rash which usually appears 1 to 3 days following the fever. A probable case is one that meets the clinical case definition, however, is yet to be lab confirmed but has a strong epidemiological link to a confirmed case. Confirmed cases are those patients who are clinically compatible and laboratory confirmed. Lab confirmation is usually based on real-time PCR from the samples obtained from the lesion. The common specimen includes skin lesions such as swab from the lesion or a biopsy. It is important to sample more than one lesion from different locations in order to increase the sensitivity of the test. While doing swab, ideally, two lesions should be collected in a single tube, preferably from different locations of the body. We need to ensure deep swabbing by passing the swab 2 to 3 times on the lesion. Ensure that the vesicular or the pustular component is collected on the tip of the sterile swab. The collected material is transported in a viral transport media and kept refrigerated at 2 to 8 degrees Celsius. While collecting tissue samples, it is important to unroof the scab or crust carefully. Place the scab or crust collected into a sterile container. All the specimens need to be triple packed. The swab has to be transported in a universal transport media at 4 to 8 degrees Celsius within 48 hours of collection. Tissue samples collected in a sterile tube need to be transported as soon as possible. Serological studies such as antigen or antibody detection are currently not recommended due to cross-reactivity with other orthopox virus. Recent or remote vaccination with vaccinia-based vaccines can also cause false positivity. PCR-based blood tests are still not recommended for monkeypox infection due to the variable duration of antigenemia and a long incubation period. The case fatality rate is estimated to be 1 to 10% based on earlier reports from Africa. However, most of the illnesses are usually mild and the current West African clade has a lesser mortality rate. Secondary bacterial infection of the skin and eyes are the most common complication following monkeypox infection. Diarrhea and vomiting leading on to dehydration may also prompt hospital admission. Other common complications include abscesses with airway obstruction, bronchopneumonia. Encephalitis is a rare complication of monkeypox infection. The common danger sites may include loss of vision, delirium, loss of consciousness and convulsion, respiratory distress, bleeding, oliguria, and other signs of sepsis. The common risk factors for severe disease and mortality are infection in children and pregnant women, immunocompromised status, and the strain of infecting virus. Previous smallpox vaccination seems to be protective in monkeypox infection. The treatment of monkeypox infection is essentially supportive. Fever and adequate pain control is essential. Paracetamol is the preferred drug for fever control. NSAIDs are better avoided as there is a risk of bleeding from the ulcer sites. Skin, eye, and oral mucosal care are extremely important. Adequate use of lubricants and avoiding rubbing of vesicles and the scabs are very essential in order to prevent scarring. External cooling mats may be used in order to reduce fever as well as soothing the patient. Any person presenting to us with respiratory distress or failure need to be hospitalized and treated appropriately. Since there is extensive loss of fluid from the skin and mucosa, adequate hydration and nutritional support is essential. It is important to recognize and treat complications early. Antivirals may be used in high-risk cases and in those to prevent progression of illness. Tecovirimat can be used at daily doses for 2 weeks. Tecovirimat is a translation inhibitor. It was primarily developed for smallpox infection. However, this drug is still not widely available for use. Brincidofovir is another drug which can be administered weekly for 2 weeks. People who have been exposed to the virus need to undergo home isolation in a separate, well-ventilated room with attached bathroom. Adequate hand wash, use separate bathroom and separate clothes in order to prevent spread of infection. Physical distancing and use of masks can prevent droplet spread of this infection. The caregiver should continue to wear masks, avoiding direct contact with patient secretions or contaminated items. The utensils used by the person need to be cleaned separately with a detergent. A 21-day isolation is needed following exposure to the virus. The isolation practices are quite similar to those used for COVID-19 infection. For the prevention of monkeypox infection, especially in the post-exposure phase, two vaccines are currently approved. ACAM 2000 is a live vaccinia virus that is licensed for use in adults more than 18 years of age. It was primarily developed for smallpox infection. Due to its replicating nature, following a successful inoculation, a lesion at the site of vaccine develops. This lesion suggests a good uptake of the vaccine. Following this, the virus starts to replicate in other parts of the body and mounts an antibody response that helps in prevention of the monkeypox. Jynneos is a live attenuated virus which is given as two subcutaneous injections 4 weeks apart. There is no visible take unlike the ACAM 2000, and usually the immunogenicity is confirmed by the blood tests. Both these vaccines are about 85% effective in preventing monkeypox. Vaccinia immunoglobulins are also used as a part of post-exposure prophylaxis in high-risk individuals. If you like this video, please follow us at the following platforms for more updates.